name is Eva Dembowski. I work at Northwest Community Hospital. I have offices in Arlington Heights and Schaumburg. I have had an interest in women's heart disease for several years now. I spent majority of my early career in academic medicine, where I specialized in women's heart, worked under some pretty established female cardiologists who also were my mentors, Dr. Annabelle Vogelman at Rush and Dr. Marla Mendelson at Northwestern. So I was very fortunate to see very, very good women's heart programs and their research in those institutions. Now I've been at this community hospital here in our Northwest Community for the last 2 years now.
Okay.
So I was not sure how much of this would just be question answer versus how much you would like to first hear me say a little bit about women's heart disease.
Well, why don't
So I don't know.
and I'll jump in. Did you get the questions I sent you, or did they not get them?
I do have a list of questions from the email, yes.
Okay, well, if you're more comfortable doing a kind of an introductory overview, why don't you do that, and then we'll go to the questions.
Sure. And I should ask, how long typically do you guys meet? Because I can talk about women's heart disease for hours and hours.
The meeting usually lasts about an hour, but the presentation maybe 40 minutes, and then we open it up to questions from the floor. And actually, people can jump in while you're speaking too. So
absolutely, if anybody has a question at any time, please go ahead and just chime in. So happy to field questions as we go.
Okay, why don't you begin then? Thank you.
So I think it's important first to establish the scope of the problem.
Oh, there we go.
This is a good question always to start off with, which is heart disease really a male disease or a female disease? Because for many decades, it was thought that heart disease was much more prevalent among men than women. And it's important kind of to look at our statistics in the United States, with men being here in the blue, women being here in the red. And as you see, for the last, from the 1990s, 1985 on, more women were dying of heart disease than men. And really, that didn't flip until around 2012, where suddenly the statistics for women started to improve. And now we're seeing that actually more men are dying of the disease. So important to remember that it has not always been just a male disease, although it's been thought to be. And the reason for that is that men will present at a younger age. Women tend to present a little bit older. And therefore, the focus was not historically on women in heart disease. But luckily, we've had wonderful campaigning groups such as the American Heart Association Go Red Project that really started to give women a more prominent mention when it comes to heart disease. So another false statement is that breast cancer is the #1 killer of women. I think this statement is still thought of as true because, again, breast cancer tends to affect younger women, heart disease more older women. But when you really look at the statistics, you can tell here that heart disease, by far, more women die of heart disease than all cancers combined. And certainly much more than what the COVID epidemic did to us.
Yeah.
But here's my where advocacy is really still so important, which is why I'm so happy when people ask to hear this, a talk or have a question answer session on this topic, because we still need to advocate among women. When American Heart Association does these surveillance studies of what do women out there think that is the leading cause of death or their leading problem in health, more than half of women still remain unaware that heart disease is the leading cause of death. And if you see here, 2009, 65% of women appropriately identified heart disease as the number one leading cause of death. And in 2019, 44%. So women are becoming a little less aware. Why was this statistic so good in 2009? Well, it was the American Go Red campaign that was really very robust. And in 2019, as we get other advocacy groups, and maybe we're not putting as much attention anymore on the red dress campaign, we're starting to lose awareness. So very important to continue to drive home the point that heart disease matters for women, that really women should be paying attention to their heart health. And then part of what I'm very interested in is research. So historically in our cardiovascular trials, women were very underrepresented. When we would do a trial, it would be predominantly white men that were in these trials. And in the recent years, that has definitely improved, where we're seeing a lot more women involved in trials, which is very important, because just because a medication or an intervention or a device works in men does not mean that that translates necessarily to benefit in women. So very important for our female patients to become educated that there could be trials that they would be appropriate for and enrolled if appropriate. So I think everyone here probably knows, but important to remember that heart disease can present differently in men and women. Men tend to experience more classic symptoms of heart issues, chest pain, shortness of breath, nausea. But the spectrum of symptoms that women talk about when they have heart disease is very, very much wider. And therefore, it often can be confusing for women to identify it as a symptom from their heart. So sometimes the only symptom a woman can have is just feeling tired with activity, and that might be their heart disease. So always important as a physician, when I see a woman, I have to deal with many more symptoms to tease out, is this something that's going to lead to their heart disease or not? Not to say that men can't have non-specific symptoms, but they're just much more common in women. Very important to tell our women patients to call 911 if they think they're having a significant symptom. Another barrier, I think, in women's heart disease is this feeling among women that they're going to just wait it out and see what happens. And we know with any kind of heart events, the sooner you get to help, the sooner you get to a hospital, the better you'll do. Here's a very interesting kind of concept that we've learned in the last decade among women, in that women tend to have different types of heart disease. So this was a question I'm sure we'll circle back to. One of the questions that was given to me is that women can have heart attacks without having a blockage. So can men, but much more common among women. When you think of a heart attack, what is a heart attack? Well, a heart attack is the cessation of blood flow to part of the heart muscle. Here, typically is shown that usually that's because of plaque. The vast majority of heart attacks that we talk about, it's because plaque has built up in an artery and then goes from being very small to all of a sudden blocking you, very, very largely. And we get a very dramatic EKG, and then we, kind of have to save you and do something to you very quickly. Well, here's what you usually do is you go to the cath lab, right? So here's a cath lab where somebody's artery was completely plugged by plaque, by a plaque rupture. And then through the cath lab, you open up the artery and you restore blood flow. Well, what we've uncovered is that what we see on the angiogram, those big vessels, that's just the tip of the iceberg. Really, this is what your coronary arteries look like. This is a model taken from a putting plastic, it's an autopsy model. It's not a true angiogram. So when you go in for an angiogram, this is what your heart angiogram looks like. But here's the model of really what the intricate coronary structure is like, all those little tiny capillaries. And that microvascular system is so important, and sometimes maybe even much more important for women. So again, the macro system that we see on an angiogram and the micro system that we see, autopsy, we can't really visualize these vessels, in our studies, but certainly they're important to your heart health. Women tend to have, are much more likely that they might have problems in that microvascular system. Those are the type of heart attacks that can happen because of that microvascular system among people that don't have plaque in their heart arteries. This phenomenon called myocardial infarction with no obstructive coronary artery disease is much more common in women. And that can be due from all sorts of different reasons. Either you can have dysfunction in that microvascular bed where those arteries spasm, they close and open, close and open. You can also have a tear in your arteries. Those are called coronary artery dissection. That's much more likely, no plaque reasons. You can have stress-induced heart dysfunction. So broader differential sometimes of heart attacks than you see in men. Again, men can have these different types of heart attacks, but this phenomenon much more common in women. Another thing that I think is important with women is to remember that women have an entire hormonal lifespan, many different events that lead to pregnancy, that lead then to menopause, will affect the heart differently. And it's important to kind of think about the woman in the phase of reproductive life that they exist, because heart function will change based upon that reproductive cycle. Important to remember that even in your younger years, you can have the starts of atherosclerosis. So really advocating for the fact that we should be really talking even to our children about prevention of heart disease, not necessarily medical prevention with pharmacology, but to eat heart healthy, to move, to develop those lifestyle benefits early in childhood. Pregnancy, big problem for some women who have potentially unmasked heart disease. We know that in the United States, our maternal mortality is not good compared to other industrialized countries. We don't do well with maternal mortality. And the leading cause of problems in pregnancy for women in the United States is cardiovascular disease. So very important to kind of identify those heart risks in our pregnant women. We do a lot of preconception counseling. We feel strongly in cardiology now that we should prepare women for pregnancy, that it's not just something that easily can happen. We have to actually think about, do they have risk for heart disease in order to achieve a successful pregnancy? We also know that if you've had a pregnancy where there could have been a complication during that pregnancy, that later on you're at more risk for heart disease. So our patients that have had high blood pressure in pregnancy, or preeclampsia, or babies that were small for gestational age or sustained a preterm delivery, they will have potentially more heart disease in the future. So that group of women definitely needs to work with a team that recognizes their future heart risk.
And doctor, even could you go back to that slide for a second?
Yeah.
So
go ahead.
You're saying even as much as more than 10 years out, they could see the impact of that, right? Am I reading this right?
Oh, absolutely. Absolutely. So all of those events that could have happened to them during their pregnancy have short-term risk, but also long-term risk. So it's very important that a woman that has had one of these events needs to establish care doesn't necessarily need to be with a cardiologist, but with someone who understands that risk and can potentially do things, monitor things that will decrease her future risk of heart disease. Absolutely.
Okay, thank you.
So menopause is another whole time frame that is really impacts a woman's heart. This is a time frame where we see a lot of risk factors develop in that lead to heart disease. We know that estrogen is very good for your heart. Many, both human models in research trials as well as animal models, show us that estrogen has all sorts of benefits on heart muscle cells, but also on vascular system. So naturally, when a woman loses her estrogen, we would think that that's when the heart risk really starts. And that's exactly what human trials show us. So if you plot out menopause, which usually happens to women in around early 50s, late 40s, early 50s, you see a tremendous amount of risk that grows. Here's coronary heart risk versus age right after those menopausal years, almost like a takeoff of heart disease. Estrogen is also probably the reason that women will show their heart disease later in life, as I told you before, where men seem to be younger at the time of their heart disease. Women are somewhat protected in those reproductive years with estrogen, so it really doesn't take off until after menopause. So there is that delay potentially because of the benefits of estrogen. So because we know that menopause is such an important time frame, that's another time frame where someone should pay attention to, is this person developing those heart risks? Are they having hypertension at this stage? Are they gaining weight, which is very common in menopause? Are their cholesterol parameters changing? Lots of monitoring should be happening during this time frame to really see those risks. Hormone therapy is getting a kind of back and forth. Should we do this to women? Is it a good thing? It's a very complicated decision, but something also that cardiologists are becoming more and more aware of and more involved in is discussing whether there's benefit to hormone therapy. The thought being that maybe some women will actually decrease some of their risks, or could it even be safe for women? Is it risky for women to take? So lots of conversations can be happening here in the cardiac clinic if a woman is contemplating hormone therapy. Usually this is a woman that is contemplating it because they've discussed it with their gynecologist, but then that gynecologist will refer to a women's heart specialist in order to have deeper discussions as to the heart implications of hormone therapy. Women also in their older ages, so now moving away from menopause, have something called diastolic heart failure, much more common than systolic heart failure. So important to remember that women have a pump function. So all hearts have a pump function, a squeezing function called systolic function, and a relaxation function, so diastolic function. And when we talk about heart failure, which is the inability of your pump to work, you can have a problem with the systole, which is the squeezing, or you can also have a problem with diastole, which is relaxing. Women tend to have more diastolic heart failure than men. That's the stiffness of the heart or the inability to accept the blood. Some people feel that this might be, again, secondary to estrogen, that estrogen promotes, helps, is beneficial to this stiffness, so to keep things kind of pliable. And the thought is that maybe after menopause, the stiffness happens in some women, regardless of which heart failure looks very different sometimes in women because of this. And the sad thing about the diastolic heart failure is that it can often lead to a lot worse symptoms. These patients tend to have significantly more symptomatic years, whereas the systolic heart failure or the reduced ejection fraction, they tend to have more more mortality. So that's bad too, that the chance of death is higher in when you have a systolic problem. But the preserved ejection fraction tend to have a lot of symptoms, a lot of comorbidities. It gets very hard to kind of function in life. And the predominance is more women with the heart failure preserved ejection fraction or the diastolic, and the men with the systolic dysfunction. So lots of these little nuances to kind of women's heart disease that have to be thought through. Women also have different risk factors that they have to bring to the table, namely on this kind of page. When you talk to patients, you think about risks of diabetes, risk of smoking, risk of physical inactivity, risk of high blood pressure. These are all pretty common in both men and women. But when you think about a woman, now you have to talk about those pregnancy risk factors. Women have more autoimmune disease, such as lupus, rheumatoid arthritis. That can lead to heart disease. Women have things like potential breast cancer treatment that they've gone to. That can lead to future heart disease. So there's just a little bit more things to discuss or unravel in the medical history, often with a woman, that become important to address and make sure that you've covered in terms of kind of figuring out what is the risk for future heart disease. I'm going to stop there because the rest of this is kind of more, I'm just going to open it up for questions first, and then we can talk about, because I wanted to give you a landscape of kind of what types of things I do, what types of things I think about when I think about a woman's heart disease, but I know that there were specific questions. So maybe we'll talk about first those specific questions, and then we can circle back to what can we do when we have these risk factors? What is the program to get our hearts stronger and better? And you'll find that there's a lot of commonalities with men's heart disease as well, but important to kind of highlight differences for women as well. So go ahead. I'm going to open it up for questions.
Okay, thank you, doctor. I'll start off, but if anyone wants to jump in, just you can put it in the chat or you can unmute yourself. And for folks in the room, just be ready to jump in if you like. So what are the most common heart ailments for women? Can you quantify which they?
Yeah, by far, I would say that they're still going to be the common ones are still going to be the same as for men, with just caveats in them. So number one would be atherosclerosis, so plaque in your heart arteries. That is a very common still problem. Women have heart attacks. They have coronary disease. They have angina. But again, those nuances, for example, within that heart disease. So for example, with coronary disease, the fact that maybe your angina as a woman is not described as chest pain. You might have subtle symptoms. You might also have it where the technical ramifications of diagnosing it is a little bit different. So stress testing in a woman is often a little bit more difficult than men because there's certain parts of stress tests that are less reliable, and that's mainly the EKG. EKGs often in women can be either silent or abnormal, and that isn't as telling as the pictures on the EKG. So you have to kind of think about that when you see a woman. Mm-hmm. Women's coronaries, their actual arteries around their heart, tend to be smaller, narrower. So technical ramifications also, therefore, come to play when you put in stents, when you refer people to bypass surgery. You have to think about, do you have good targets to actually, treat appropriately? So still the same prevalence of that disease, but maybe some nuances in the management. Okay. Women often, other kind of diseases that are prevalent in women is heart failure. So as I mentioned before with that slide, heart failure is the condition where your pump, which is the heart, is not circulating the blood enough to support your organs, or it congests you, so it backs up the fluid. And that can happen either because of the squeezing function or the relaxation function. Again, heart failure is still common in men and women, but women tend to have more of the relaxation problem than the squeezing problem. Different medications are used for those two groups, different treatments for those two groups. And then the third bucket of diseases, I think, for heart disease in women is arrhythmia. So women tend to have a little bit more atrial fibrillation, so a rhythm disturbance, than men. And then in terms of treating that atrial fibrillation, women tend to have more clotting events. So they're more prone to having stroke if they have atrial fibrillation. So again, not that men don't have these diseases, because certainly none of the heart diseases are 100% unique to women. Everything can happen in either a man or a woman. It's just that the presentation could be different. The treatment could be different. And also the success of the management can be different. And so that's kind of where this, being a women's heart specialist, we have to kind of come up with those different nuances.
And are the recovery processes different? That was one of my other questions. Do women have to do different things in recovery?
Because the research has lagged in terms of treatment studies, we don't have many unique treatments for women. We extrapolate a lot of our treatments from men, but we are knowledgeable about the fact that certain things are stronger, certain treatments are better for women, or certain treatments are better for men. For example, when you have a diabetic woman, diabetic women tend to have more issues with heart disease when their blood sugars are not controlled. And so that is a very big, important aspect that I focus on, is that blood sugar control. Not that I don't for men, but for my women, I especially pay attention to that blood sugar control. So cardiometabolic influences. Women can also respond less to statins. So I still use statins for women, but I have to know that that's maybe not going to be just enough, is to put that statin for prevention on board. Post heart attack, for example, women respond very well to rehab. Rehab exercise benefits women in a stronger way in research trials than even our men. So I put a lot of emphasis in women to do rehab. The interesting thing about that is, if you kind of heard that microvascular component, again, to review, the microvascular is not the large arteries around your heart, but the little thread-like arteries that are leading all the way to the muscle. Women, for some reason, that microvascular circulatory system seems to be a little bit more important in women than in men. And that system, there's no medications for it, but it responds really well to exercise. So often a woman with microvascular issues does really, really well when she does regular rehab, regular cardiovascular exercise. So there's just some things that I think we pay attention to a little bit more with women.
Okay. And has the research caught up for women in heart disease, or there's still gaps?
Oh, there's still definitely gaps. There will probably never be revisiting of trials that are already well established in men. So things that we do in cardiology that we kind of have taken and extrapolated into women, there's no reason to revisit everything. So there will still be some trials that we continue to use with our female patients that have had predominantly male, were studied in men. And that's not wrong, because it's not as if, we're completely different from men. But certainly, I think that there's a lot of gaps in understanding unique treatments. That's what I would say, is that because of the influences of estrogen, the influences of pregnancy, menopause, a lot of those trials are still very much lagging in terms of kind of enrolling and performing the right trials in order to understand those timeframes in a woman's life.
Okay.
But certainly we are much better at enrolling women. We have definitely placed emphasis in most academic centers in really doing trials that represent our population. It's not even a woman male type of thing that we're talking about. Also talking about race, that we should really always be enrolling in our trials a similar demographic to the one that we have questions about. So in the United States, that would mean enrolling different ethnic groups in addition to enrolling different genders.
And what about testing? Is testing adapting to the different things women may have?
Absolutely. So tests, cardiovascular tests are there are some unique ones that become more important to some of these unique diseases that I'm talking about. So for example, for the microvascular system, there are certain types of stress tests that would pick that up better than the traditional stress tests. So traditionally, if you have had a stress test, you would either have a stress echocardiogram, which is an ultrasound of your heart, or a stress nuclear scan. There's two more specialized, much more costly because they're a specialized technique that's harder to obtain. It needs specialized training centers, specialized personnel. One of them is called a stress MRI, and that stress MRI we do at Endeavor. And then a little bit more rare is the stress PET, which is a type of nuclear camera that is a different technology of radioactive tracers. Both of those can look at your microvascular system, and those are becoming more and more available to our female patients. I still think that if you see a women's heart specialist, you might get referred to those a little bit more than if you see just a general cardiologist yet. But I think that will change over time as people get more comfortable with that technology, what kind of questions it can answer. You'll see utilization of those two modalities much more.
And are insurers aware of that? I mean, does that become an insurance issue?
Yeah, so for the vast majority of the cases that I send, I typically do not see trouble getting that covered.
Good.
If you start with that type of a test, that's not covered. So you pretty much have to have a reason that you're heading towards a test like that. You probably will not see many, or you should not see many people referring directly for that test. Because I should also, I mean, I think I kind of highlighted this a little bit, but I'll reiterate it. It's much more common still among women to see the same type of manifestation of heart disease that a man has. So those big blockages, the macrovascular disease, are still more common. It's just that in addition to that, they may have a greater chance of having something more rare like microvascular disease. And so to start with the big test that is a very costly test would not make sense.
Okay. Did you guys have a question? No? And so you mentioned women have the same heart issues as men, but you also touched on the sudden coronary artery dissection. And I had that in my question list because I have a friend who's, I don't know, 20 years younger than me, and she had her first attack in her 40s. And they discovered that's what it was. And at the time, there seemed very little knowledge about that. So she helped form a support group, and they're working with the Mayo Clinic now to do more research. But isn't that primarily women?
Fantastic. I was going to say, yeah.
So
So if she's in Chicago, she doesn't have.
Go ahead.
Yeah, if she's in Chicago, she doesn't have to go all the way to Mayo anymore. But
good.
Certainly Mayo, the Mayo women, the female cardiologists at Mayo were a driving force for this entity called SCAD. So SCAD, spontaneous coronary artery dissection, is right here in that middle slide. So what is that? It is basically a tear in the walls of the arteries in the coronary bed. SCAD is rare. It's rare, but it's very it's a very scary event for women that experience it, because these are usually women who have very little traditional risk factors for heart disease. So again, most heart attacks are plaque based. So that means you've developed plaque, that plaque pops, called plaque rupture, and you block your artery and you have a heart attack. We know that disease very well. We've studied it. We know the risk factors. So all those things that typically lead to those types of events are pretty well established. So when you meet a patient after that type of event, you have a lot of things to work on. It's a very hopeful conversation. Patients are usually very comfortable with the care because lots known about it. They know what medications they can receive. They feel like they can kind of understand that disease. With SCAD, we don't know a lot yet. We don't know a lot about why this happens. It certainly happens much more common in women, but it also can happen in men. It's not a disease that's unique to women. It can happen to men. I have seen male patients with it. It can be associated with stressful events. So something that happens to you that's very stressful could lead to that dissection. It can happen more commonly with people that smoke or have high blood pressure, but oftentimes the women has no seeming risk factors. It also, I should say, can happen a lot more common in pregnancy. So when we see a woman that is looking like she's having a heart attack in pregnancy, this is something at the front of my mind. Is she having a SCAD event? Unlike our normal vessels, we don't treat this with angioplasty or stents or bypass surgery. We let the artery heal on its own. The thought is that we shouldn't be touching these arteries. So it's very important that the person doing the angiogram recognizes it. I think that part we're getting a lot better at. So when I was in fellowship 20 years ago, it was thought to be so rare that not many people had seen a SCAD event. Now, both in our conferences as well as just kind of more angiograms, most interventionalists now can recognize what that looks like on the angiogram. So on that X-ray picture that I showed you of the arteries, and they know not to then go into that artery or stent it. So from that perspective, we're a lot better. And you are correct, because it's rare, we have made a push to put these women in registries so that we can, if you're a cardiologist and have seen 2 cases, you're not going to know much more than your 2 cases. But when you start to make registries of patients, you can then start to understand it and do research in it. So Mayo certainly was one of the first SCAD registries, but they have one now at Northwestern. There is a physician there who's interested in this, Rania Swice. She's a cardiologist, wonderful interventionalist. They have also that availability, that we at Endeavor can tap into both. I've sent people to the registry at Mayo as well as the one at Northwestern.
Great. I think she was at Swedish Hospital, which is also now part of Endeavor. So
Yes. So definitely the good news about that is that most women will not have a recurrent event, but there are some that do. They need to have all their arteries screened, because we look for something called fibromuscular dysplasia, which is an abnormality of your vessels, that there was something maybe wrong in the connective tissues that make up those vessels. So we screen the arteries in the neck. We look for the arteries to your kidneys, just to look if there's signs of kind of any abnormalities.
Okay. All right. Well, I'll update her on that. She's had 2, and she's still only in her 50s. So.
Okay. Yeah. So she would definitely benefit from being with a women's heart specialist for sure.
I'm sure
I know that they have. Swedish has a one. I can't remember who that is, but there is a women's heart specialist at Swedish.
Right. Questions from our members? Anyone at home? Oh, question from Jay. Go ahead.
So as a whole, what medication options do you recommend for treating heart failure? especially if there is no high blood pressure, and there are side effects from medication that's prescribed.
Did you hear that, doctor? I can repeat it for
So,
you.
please repeat it, yeah.
She asked you what medications might be appropriate for someone with heart failure who doesn't have high blood pressure and has had side effects from which medications cause the side effects?
Okay, so I'm going to go back to my heart failure slide just because I think it's important to tell you a little bit about the differences. So when you talk about heart failure, the next question every cardiologist will have is it a systolic or a squeezing function problem? Heart can't pump. Or is it a diastolic or relaxation problem, which is heart can't fill? And the reason that it's so important to know, are you here or is this person here or here, is because of what medications will impact you. So in cardiology, we're a very studied field. We study these medications not only for what do they do to your heart, but also what do they do for your life. We want to make sure that we're using medications that can improve not only the quality of your life, but the quantity of your life, and to have less heart events. So, for example, in this group, the systolic heart failure people, the patients that have poor pump, there are 4 medications which we know will make you live longer and live event-free. And that, therefore, we try very hard to use those 4 medications if you have this problem.
What can you say what they are?
Yeah, so one is a beta blocker. Those are the medications that will lower your heart rate, will lower somewhat the blood pressure, but will lower your heart rate. Another category of medication is one of 3. They're all kind of similar in that they're angiotensin receptor blockers, ACE inhibitors, or the newer one called ARNI, which those 3 categories are all kind of what we want to use one of them.
Are you taking any
the next, I'm sorry, go ahead.
I'm just asking the person who asked if she'd been taking any of those.
Yeah, so there's lots of different names in those categories. Okay. So that's the 2, I only mentioned 2 categories. So the second category is one of 3 kind of subcategories. Okay. Then there's the SGLT2 inhibitors, which were created for diabetes, but now are used in this group. And finally, there's something called mineralocorticoid receptor antagonists, MRAs. So 4 categories of drugs, very complicated. Management of this patient population can be very complicated because we're now saying our guideline committees are telling us, try to use all 4 if your patient is in here, because your patient will do better. Trials show patients will do better. Obviously, many patients kind of hear that and they just, it's mind-blowing because you're right. Some of them have low blood pressure. Some of them have side effects to medications. So it's not as easy as saying, here are your 4 medications, goodbye, but rather it's working with that patient to kind of see, could you tolerate a little bit, or maybe you can't tolerate this category of drugs, but we can do, one of the other 3. So this is a big group. And why is that so important? Remember how I told you that this group, the systolic, is more men? And this is also much more deadly of a group of patients, meaning their mortality is very high. And so we obviously want to do everything we can to prevent further deterioration of this heart and prevent heart events, prevent death. The other category of patients, this diastolic, which is more common in women can get both, but more common in women. This category, the data is not, and the research for medical management is not as strong. There are 3 categories of drugs in this category of patients that do show benefit, but the magnitude of benefit of these drugs is not as strong as in this group. So in this group of patients, I might be not as much trying to give you more and more medication if you're here and doing well and feeling well. With this group, my personal practice is to really pay attention to symptom control. Because I told you before, more common in women, and the other difference between these 2 groups is that it's much more about the symptoms. Yes, you can still die from this type of heart failure, but your life expectancy is better than this group. So when you hear people talk to you about heart failure, or if you yourself have heart failure, or if your loved ones do, very important to understand these differences and to be able to work with your physician on understanding why this medication, like what is this medication supposed to be doing for me? Am I supposed to be feeling better on it? Or is this a medication that's going to extend my life? Because sometimes you might want to tolerate some side effects if you know it's going to extend your life. But if it's a medication that's only used for symptom control and you're having a horrible side effect on it, well, then there's no reason to continue to push you on it, right? So it's very important to understand, why am I taking this? What is this medication supposed to do for me? And then working with them on what is tolerable in your life in terms of side effects. But yes, this is a very challenging. Heart failure has its own specialty. So I treat a lot of women with heart failure, but I also have wonderful colleagues that are called heart failure physicians that I absolutely will either work with if I need, or certainly if I run into trouble, if I have questions, we'll work together. Because you can imagine, with all the different types of medications and all the different treatment strategies, there's a lot to talk to about, patients like this.
Okay, well, give me a second to talk to our member for more details, because she didn't want to interrupt you.
Okay, I just, going along those lines, then what type of cardiologist should a woman seek having to, I believe it's systolic.
Okay.
But who actually, not just say a general cardiologist, there is interventional cardiologist, which would be the right cardiologist to see at this point.
Okay. Did you hear that, Doctor?
I did. So I would say that would be a heart failure at this point. If you have systolic heart failure, I would see a heart failure specialist. If you're confused with all the different disciplines that we have, all the different kind of types of cardiologists, then the best way to start is with a general cardiologist. If you're a woman, certainly you can come to a women's heart disease specialist, because I consider myself a general cardiologist that focuses on women, but I'm still a general cardiologist. And then what I do, for example, as a general cardiologist, if you have systolic heart failure, I will then refer you to a heart failure specialist. So sometimes it's confusing as to who to go to. Or if you have a need for a stent, I will refer you to an interventionalist. If you have atrial fibrillation and we need maybe a procedure to get rid of it, I will refer you to an electrophysiologist. So you can always start with a general cardiologist and be referred to a heart failure specialist. But most patients with this category of heart failure often need to see a heart failure specialist.
And my only other question is, how would one know if they have AFib? I know somebody recently in her 50s and had a mild stroke, just fortunately. And when she was being finally discharged from the hospital, it was mentioned that she needs to see a cardiologist. She had a heart monitor for 30 days and mentioned AFib. So now I'm even curious about it.
How do people know they have AFib? I found out in the cardio rehab gym here when I had a 700 thing stuck to me one day.
Yeah.
How do other people
So,
know?
oh, so now there's so many unique ways to do it. So the old school way is if you know how to check your pulse, you can feel it on your pulse. So if you know how to check your pulse, either on your wrist or in your carotid, if your pulse is not regular like a drum, but erratic, that could be AFib. Could. The only real way to tell if you have AFib is to actually get an electrical strip on you. So either doing an EKG, or nowadays we have very fancy, or a lot of people have very fancy Apple Watches, Fitbits, and that technology of those smart devices is actually pretty good at detecting AFib. So a lot of people nowadays come to me with those strips, from their little technology at home. There's this thing called KardioMobile. I don't know if you've heard of it, where people buy and they attach it to their phones and they get these little EKGs at home. Those are actually very valid data, and you could absolutely bring that to your doctor's appointment or show it to your doctor if it comes up with something abnormal. One caveat I do want to tell you, do not panic if one of those devices tells you something abnormal, because many times it's wrong. It's meant to be overly sensitive, which means that it will detect things that are normal and say it's abnormal. That's actually good for screening devices, because it alerts you to a problem sometimes when there isn't, which is okay. It doesn't want to, you don't want to miss the problem. So sometimes it'll be nothing. When patients send me these strips, I just write back and I say, no, this is completely normal. But that's the way to tell for sure. You have to have a strip. So when we said that in cardiac rehab, yeah, because you're under a monitor, you're exercising, you're monitoring your heart, we can see if you have AFib.
Mhm.
Thank you. Yeah.
Is that good? Yes, another question here. Go ahead.
Yeah, does heart failure tend to run in families? For example, if I have a parent with heart failure, am I at greater risk for heart failure?
Did you hear that, doctor? Does heart
Yes, I hear it. As with most diseases in cardiology, they're not monogenetic, which means that they're not completely necessarily that if your parent does, you will. But the chances are somewhat higher if you have that in your family history. So much of heart disease is environmental, which means it's things that we have been exposed to. For example, smoking can lead to heart disease. Diet high in saturated fat, diabetes, triggers, other things that have happened to us can create heart disease for us or give us more chances of heart disease. But it is probably true that underlying there's a genetic predisposition, because certainly of some people that have, let's say, high blood pressure and don't end up developing, heart disease. And that's because probably underlying there are genetic predispositions. So it's very important to give that information of the family history to your primary care physician so that they're on alert for what could be in your future. So kind of an indirect way of saying not always, but sometimes, yes, it is more common if you have, genetics.
Mhm. Okay. Any other questions in the room here? Anybody online? Last chance? Because we're past 7:30 here. Thank you so much, doctor. This was really great.
Absolutely.
It's really
Happy
great.
to join you guys. Happy to join you guys. And if you have any further questions, maybe here, I can just put it into the chat. You can always feel free to email me.
Great.
Can I do that in the chat? Here we go. Yeah, I'm just gonna write my email in the chat for everybody to
And
be able to see.
I'll put
And
it online on our website too, so people can contact you.
okay, so at any moment, happy to answer any questions, because I know that sometimes it is very complicated, but we are here for you. I enjoy always talking to community groups, because I think it's just so important just to recognize the importance of heart disease.
Great. Well, thank you so much. It's great to have you.
Okay, thank you. Bye-bye.